activities. So this is the pediatric chapter. We are starting our activity for this new chapter today. And our speaker is Dr. Abdulaziz Shahrani. Dr. Abdulaziz is a senior fellow and he's now in his second year of training at King Abdullah Specialized Children Hospital. And he's going to present today targeting zero medication errors in pediatric intensive care. This is a quality improvement project that he was working on with his colleagues and is supervised today and as well in his project by Dr. Hamza Al-Ali, who is a senior pediatric critical care consultant. And he's as well a leader in the quality field. Please welcome with me Dr. Abdulaziz and Dr. Hamza Al-Ali. And Dr. Abdulaziz, the floor is yours.
Thank you, Dr. Aida. Assalamu alaikum. Good evening, everyone. I am Abdulaziz Shahrani, a pediatric critical care fellow. Me with my supervisor, Dr. Hamza Al-Ali, critical care consultant in King Abdullah Specialized Children's Hospital, National Guard, Riyadh, will be presenting today a quality improvement project targeting zero medication errors in pediatric intensive care. So we'll start with my objectives. The first objective to explain basic knowledge of quality improvement science. Second is to provide an example of a quality improvement application in a pediatric critical care. And then present a successful multidisciplinary quality improvement project to reduce medication administration errors in critical care settings. This is the outline of the presentation. First, an introduction to a quality improvement science, and then what is medication error and the quality improvement project aim, setting, methods, results, and then conclusion. First of all, a quality improvement consists of a systematic and continuous actions that lead to a measurable improvement in healthcare services and health status of a targeted patient groups. The Institute of Medicine Health defines quality in healthcare as a direct correlation between the level of improved sciences, services, and the desired health outcomes of individuals and populations. Here at the quality management principles we're focusing today, usually you start with as a customer focus, which is the patient focus, work on improvements with an evidence-based decision making or evidence-based decision medicine, and you work on a process approach, and you will form a team engaging people, and this requires good leadership skills. Here an example of a quality improvement application for a pediatric critical care. There are multiple examples, one of which is the ventilator-associated pneumonia, where you have where you want to go for an outcome measures, you have to go through a process measures such as head elevation, mouth care, early appropriate diagnostic measures, antibiotic therapy, to decrease the incidence of ventilator-associated pneumonia and to increase the compliance with these individual processes. Other examples include CLABSI, sepsis, sedation, liberation from mechanical ventilation, and blood transfusions. One of the major things that we are going to talk about are medical errors, which need a lot of improvements. According to the recent data, up to almost 100,000 American lives each year are having any medical error, which is the 8th leading cause of death in the United States. Up to 7,000 of these deaths are attributed to an adverse drug events from medication errors. And at least 1.5 million preventable adverse drug events happen in the US each year. So what is the medication error? It's any preventable event that may cause or lead to an inappropriate medication use or patient harm while the medication is in the control of a healthcare professional, a patient, or consumer. The burden of this mortality and morbidity associated with medical errors is such that the World Health Organization has committed to a global program of work to reduce the harm of patients caused by medical errors by 50% by 2022. The rate of medical errors in our clinical intensive care units is different than in patients who are admitted in wards for many reasons. For example, the disease complexity with a rapidly changing physiology, increased number of medications that intravenously administered, and increased staff workload. So now we will talk about our quality improvement project. So any component of any quality improvement project, it has it is based on mainly 5 key components, which are the first of all to identify the problem, to set a goal and then aim for it, and measures and then analysis or analytics. So the problem with in our unit, it was noticed that the number of reported medication administration errors was increased gradually during the year 2018. So a quality improvement team was collected as baseline data prospectively during the second half of 2019, which proved this observation. It was shown that medications administration error rate range between 5 to 8 medication error per 1,000 patient day. This result was considered as a baseline measurement before the improvement interventions took place. Here is the number of medication errors by month, which was collected prospectively during 2019. It was collected utilizing the safety reporting system in our unit. And you notice the number of medication errors each month. So quality improvement initiative aimed to reduce these medication errors incidents and improve medication administration practices in the pediatric intensive care unit. Medication error may occur during any stage of medicine process, which include prescribing, dispensing, and administration, but for multiple reasons and the process complexity and involvement of too many services, such as medical teams, clinical pharmacy, pharmacy automation, technology, and information management system department, we elected we decided to target only the errors that reach the patient directly. So our aim for this project was to reduce medication administration error rate to 0 by the end of 2021 in our PICU setting. Setting is, it was operated or conducted in PICU unit at King Abdullah Specialized Children's Hospital, which is an academic governmental tertiary hospital in King Abdulaziz Medical City, Riyadh. It consists of 25 surgical and medical beds, admitting patients from 0 to 14 years of age, and the average number of admissions exceeds 1,000 per year. So first of all, definitions. A medical administration error was considered if a patient received a wrong dose, a wrong drug, wrong route, wrong administration time, or dose omission. Medication administration errors rate was considered as the outcome measure for our project, and it was calculated as the number of errors per 1,000 patient days, which was reported quarterly. Here are our measures. We chose that medication error administration rate as an outcome, as the number of errors reaching a patient per 1,000 patient days, which was reviewed quarterly. And of the following, the CLMA compliance rate, which is the closed loop medication administration, drug library compliance rate, and independent double check compliance rate as a process, which was reviewed monthly. Here is a driver diagram, which gives you the idea. In order to reach your aim, you have to go for a secondary driver. This will lead to your primary driver um, accomplishment, and then finally to your aim. It has multiple steps we will explain in this presentation. And mainly the primary drivers are medication error awareness, CLMA compliance, drug library utilization, body system compliance, and electronic order set utilization. So in our methods, based on the model for improvement methodology, we utilize the plan, do, study, act cycles to develop, test, and implement the improvement interventions. There are 5 PDSA cycles were executed over the project period. The compliance rate for the proposed interventions were reported monthly, as mentioned, with an action plan when needed. Here, a diagram a diagram showing how the plan, do, study, act work. So first of all, you plan, you describe your objective, change what is needed to be changed, needed actions, and a plan for collecting your data. Then you run your test, describe what happens, collect the data, and then later you study it, you analyze your data, you compare the outcomes, and you summarize what you have learned, and then act in terms of deciding what's next, making the changes, and starting another cycle. So first PDSA cycle was the awareness campaign. So the plan was to make nursing staff and other staff in the unit aware about the 5 rights of medication administration, the stages of and the level of harm that patient might endure during medication error, which are the right person, the right dose, the right medicine, the right time, and the right way. Multiple educational session was carried out for the nurses, pharmacists. Number of medication administration errors was displayed on a handwriting whiteboard during the PICU daily safety huddle to promote transparency, culture, and increase awareness. Here in the photo below is the showing when was the last medication error, when was it happened, and the other one is the 0 unplanned extubation days. This is a picture board in our unit. Then we'll go to a study. So we targeted 100% of ICU staff by the educational sessions, which was achieved by the end of 2019, the 4th quarter. Types of medication errors were administered and continuously measured and analyzed. Based on this feedback from the staff, education continued and the quality improvement team planned the next step of improvement strategy. Here a picture of the Huddle board, a similar board that we have in our unit, which is an efficient communication technique to allow teams to share information, identify concern, collaborate, and effectively engage interdisciplinary team members. This includes the medical team, the respiratory therapist, the pharmacist, clinical pharmacist, and nursing staff, where you have any updates in the unit, any improvement ideas, any work in progress that we need to work on, any ideas implemented, and any escalation needed to be done. The second cycle, the second PDSA cycle, was the monitoring of the closed loop medication administration. So the plan was a CLMA proper education for all PICU nurses with the IT support, and we targeted a compliance rate of more than 90%. So in the picture on the right side, there is the CLMA device, which is scanning the barcode from the medication dispensed from the pharmacy specific for each patient. This barcode was initiated from the process of ordering the medication before and dispensing it from the pharmacy. So multiple educational sessions were done. The compliance rate was monitored continuously. As you can see, the compliance rate for the quarters of 2020 and 21 was monitored, and alhamdulillah, we achieved a good compliance rate, more than 90%. Later, any issues emerged during this implementation was discussed and resolved by the quality improvement team. The third cycle, the drug library, the plan is to use the drug library infusion pumps. These pumps are updated and include a pediatric dosing program with two safety limits, a soft limit and a hard limit. A soft limit will give you a warning or a message in the infusion pump, and a hard limit where you cannot administer the medication. Nursing education for the proper usage was completed, and the compliance rate was monitored monthly and targeting more than 90%. And then a root cause analysis for any deviation from the standard process or medication error with an action plan done by the quality improvement team. The fourth cycle was the independent double check. We planned a reinforcement plan for the independent double check. Here we have two nurses, nurse A and nurse B, usually the primary nurse and the charge nurse in the unit, checking the proper medication dose and route for this specific patient. And we can notice here that they are wearing some papers identifying that they are busy and not to be disturbed. The compliance rate for this independent double checking was monthly monitored also, targeting more than 90% rate. And then later, any deviation from this standard process, a root cause analysis and action plan was done by the quality improvement team. The fifth cycle, the electronic order set, where you have an electronic PICU order set implementation. It's an electronic order set created by a physician, a PICU physician, where you have doses and concentration of medication were reviewed and approved by a clinical pharmacist and a PICU staff nurse. Education sessions were targeted all staff involving an ordering process, such as trainees and staff. And this education was monthly because we have rotating fellows and rotating residents coming to our unit. So this education was monthly done. A compliance rate to the order set was measured through a survey administered to the PICU resident and fellows, targeting more than 90% compliance rate. And then later, any problems arise or any difficulty, education to this order set was done to the resident or the fellow in a monthly fashion. Here, a picture of our system, the best care, which was including a serial of order sets for each department. And you can see here the PICU, and you can see there are specific tabs where you can choose and admission orders, medications, fluids, blood products, and others such as sedation and others. Here are the results for our project. This on the left side, you can see the number of medication errors per 1,000 patient day rate. And on the lower side, you can see the quarterly results for any medication errors happened. You can see how did we start and how we ended, and this is considered as a big achievement for our unit. You can see the timeline where each PDSA cycle was reinforced. So starting with awareness, then adding CLMA, double check, drug library, infusion pumps, and then later the fifth cycle, the order set, until we reach 0 medication administration errors in the first quarter of 2022. during our data collection, we managed to collect the types of medication errors that we see each year, and you can notice how much different of the number between 2019, 2020, and 2021, where you reach up to 49 number of medication administration error compared to 13 in 2021. We managed also to eliminate some types of administration errors, such as prescribing error, improper preparation, wrong administration technique. So, lesson learned, we have learned a lot of messages from our project. Medication errors and adverse drug reactions are preventable incidents that can be reduced by implementing a bundled interventions, utilizing human and artificial intelligence, such as CLMA, drug library, electronic order set. We learned also that the nursing are the cornerstone of leading such quality improvement project and bring it to success. Of course, COVID-19 pandemic burden on the healthcare system delayed the implementing some of this quality improvement project steps, but overcoming this COVID-19 situation to move on and reach to the ultimate goal was really inspiring. Now we have reached to a control phase. We want to sustain our achievement by monitoring the compliance to the process and the outcome measures, root cause analysis for each medication error with an action plan for prevention. And we want to spread the success by presenting this in such meetings and presenting this to any international conferences, and it's on its way to publication, inshallah. Good news that this project was accepted for an oral presentation in the World Federation of Pediatric Intensive and Critical Care Society next July in Cape Town, and our publication is in progress. Special thanks to the PICU team, the PICU nurses, all team involved in this project. And thank you, everyone.
Thank you, Abdulaziz, for this very interesting talk and informative steps in regards to such a quality project. If you allow me, I want to ask you about what were the major challenges that you faced and the major obstacles that were related to medication errors. And did you link that with the type of patients, like highly critical patients, sick patients, regards to a stable or chronic patients, or the type of medications? If you can elaborate more on those aspects.
Okay, so always change is always difficult, and it requires a lot of hard work, and it requires the collaboration of all the team involved in the PICU. I think the team was really amazing, involving all specialties around the unit. There was some difficulties in identifying. Sometimes people, they feel guilty, or sometimes they feel attacked when you encounter these errors. But then later, our focus was to improve the patient care and not to point fingers to each person in the unit. Ultimately, we are all working together to the ultimate care for our patients.
Thank you, Dr. Abdulaziz. The floor is open for any comments or questions.
السلام عليكم جميعا. If you allowed me, Dr. Aida.
تفضل دكتور حمزة.
Assalamu alaikum. This is Dr. Hamza. I was like monitoring Abdulaziz and supervising him. I am involved in this project from the beginning, co-leader, with our valuable nurses, it was quite successful to achieve this zero medication error. طبعا the challenge now is to sustain that achievement, inshallah ta'ala. We intended to present this project to you guys just to give you an example how quality improvement science is applied with the correct methodology. It might change things that you might think it's not there. So many of these PDSAs or interventions, it was already in place, like for example, the CLMA or reporting, for example, but we were not sure, was it done in the right way? How is the magnitude of the problem? And we noticed that we have high rate of error. So we initiated this quality improvement project. We noticed that some interventions, it was there, but it wasn't monitored, it wasn't done properly. Other interventions, like drug library, for example, it was for adult, but it wasn't updated for pediatrics. The compliance to CLMA, it wasn't that, optimal. And other interventions was new, like order set, it wasn't there. And the soft and hard limits, it wasn't there in drug library. So through the quality improvement methodology, you find things that already there, but you need to improve it, or you do your innovation and do steps that you think it might intervene. And the quality improvement science, it's really an emerging science in critical care. And I encourage everybody to learn about it and start implement this science in your unit. And we believe really it will help and improve patient safety and outcome ultimately at the end. One of the major challenges, as Dr. Aida asked, it was COVID. I think it was mentioned in the unit. We were planning to finish the project at the end of 2020, but because of the burden of COVID, the number of patients, the limitations for the team, and the team were engaged with many things other than this project. So there was some delay in implementing some interventions, but alhamdulillah, we continued, we overcome all challenges, and we achieved our target at the end. Thank you very much. Any question, we are happy to answer.
Assalamu alaikum. Dr. Aida, you can hear me? Hello.
Yes, Dr. Hani, تفضل.
يعطيكم العافية. أولاً, thank you very much for presenting this very exciting topic. بصراحة, I really first of all, let me congratulate the whole team. It's really an honor to see such a collaboration, such a leadership in the team, the dynamics between the physician, nurses, pharmacy. It's really wonderful. And even your team had the flexibility that to continue to sustain during the COVID crisis. So I think this is something that really also needs to be added, that you may expect or actually you may have unexpected drawbacks during any project, quality project implementation. So I think you did it very well. And Dr. Abdulaziz, you presented it very nicely, mashallah. I really have to congratulate you. The one point I will ask is, as you have mentioned, Dr. Hamza, that yes, many of these aspects were maybe already there on place, or some hospitals, they may not have the whole PDCA capacities to do all of these such 5 interventions. So if I may ask you as an take-home message for other hospitals, which one was, I don't know if that's applicable question, but which was the most dramatic in reducing the errors during your process? So maybe this will be my question, and thank you again.
Thank you very much, Dr. Hani, for your question. Actually, it's hard to tell in a bundled interventions like CLABSI bundle, VAR bundle, whatever, which one specifically introduced or produced the significant improvement. I would recommend really whatever you have in your unit or an institution or whatever you can do, you just try to implement it and put it to a methodological interventions through the BDSA, whatever another quality improvement methodology, and do it. And the second important point is monitoring yourself, monitoring your achievement, analyze the data, and every time you think that you are not doing well or the improvement is not achieved to the magnitude that you are aiming, try to find something else. We started with the awareness and monitoring and collecting data. I think that was something crucial, something very important and fundamental to just enlighten us how is the problem, what is the magnitude of the problem, how can we improve it. فمثل ما بيقولوا يعني when you know the problem, I think you solve 50% of it. But again, when you have abundant interventions, it's really hard to tell which one is the most important one. I think all of them are important, but awareness is very important one. And again, just implement and monitor yourself, whatever you have in your institution, or you are capable to do it in your institution or in your PICU. And I think that will be a great achievement for your patient safety.
I think that's a very important take-home message for all colleagues. That's whatever you're having to proceed with it. One last notion, since I don't see any other raised hands. I think probably this project did not cost you any financial extra costs. It's only the time and dedication of the teams, correct?
Yes, exactly.
So I think that's a wonderful, So I think that's a wonderful idea. So you are making not only zero medication error with a zero added budget. It's just a time allocation. I think that's a wonderful idea. Thank you again.
Thank you, Dr. Han.
Thank you, Dr. Hani. Any other comments or questions to the presenting team? Let me ask the presenting team. So during the maintenance, how frequently you will monitor and how closely you will monitor the performance to make sure that you will keep the same targets?
Thank you, Dr. Aida. Usually when you reach the control phase or maintenance phase, usually you need like 6 data points within your target. For example, we are targeting 0, or for example, you are targeting below 2, for example, per 1,000 patient days as a goal. We need like 6 data points below that target or within the target that we are aiming to achieve. After that, we move from the quality improvement project to the practice point after we sustain for 6 data points. If we sit with the team, we see what is the data that we need to monitor, what is the basics that we need to achieve. For example, for our unit, we have the medication error rate itself. It's projected in our quality board. We have a quality board in the unit. It has a lot of KPIs and the unit performance, number of admissions, a lot of KPIs is projected on monthly basis. One of it is the medication administration error. After we reach this stage of improvement and we could sustain it for like 6 data points, then we will go and monitor ourselves by the outcome, which is the medication error. The next step we do, I think it was mentioned during Abdulaziz's presentation, that whenever we have an event or incident, each incident, it mandates a root cause analysis to see what happened and why there was a breach to this sustainability of the target. And if you found like they're major or it was repetitive, then we might sit again among the quality team and see what other intervention we need again.
الو السلام عليكم جميعا.
تفضلي دكتورة إيمان، تفضلي.
أهلا دكتورة عايدة ومبروك ما شاء الله. Good study, and I wish you could have يعني explained this study in a more detail. يعني explain these abbreviations because something new concept for us. My question to Dr. Hamza, I mean, what was the most common error? I mean, is it the wrong drug by itself, the wrong dose, or the wrong route of administration? And let's say you have picked a wrong drug, not needed for the patient. So, and the dose is okay, the route is okay. So how you will pick this at the time of administration?
Thank you very much, Dr. Iman, and happy to hear your voice again.
Yeah,
A long
thank
time
you.
ago. Okay, regarding the type of errors, as Abdulaziz mentioned, and I think you can put these columns that will show the type of errors, Abdulaziz. We have all types of error initially, but then most of it was delays. So it's time problem. If you noticed, total, then the wrong time was the major problem that caused which is considered a medication error. And at the end of the project, still the wrong timing is the most common. There is, of course, some errors regarding the dose, regarding the medication itself, but it's not that much. But the major category was under the wrong timing. So there's delay, there's omission of a dose or delay of a dose, and so on. Regarding the second question, how do we pick the type? We have a system which is a safety reporting system. Any medication error falls under the identified categories. We have specific categories when we report a medication error. For example, wrong time, wrong dose, whatever. It is reported through a safety medication system, which is we call SRS. And that's where we retrieve our data for the medication error and type of errors. That was how we collect data through that system. And that system will tell you the type of the error itself. Is it wrong drug or wrong route or whatever? So we could identify all of this through the SRS system.
I meant it's not a wrong drug by itself, but maybe it's not needed. Sometimes maybe you
What do you mean by not indicated?
Maybe not indicated, or maybe some. I mean, you confuse with other patients. I mean, like antibiotic, you instead of administering it to a certain patient, you give it to another one, but with the correct doses, with the correct.
Yeah, wrong patient. You will have like wrong patient is one type of the error. Yes, it will be reported in the SRS.
Mm-hmm.
And here it is under the other. I don't think we have wrong patient. I think it's never happened with us during the project to give a medication to another patient. It never happened. Yeah. However, it was tackled under the category here, other. However, we don't have any such error during the project.
Thank you, Dr. Hamza. And one more slide. In America, he said, I think it's causing around 100,000 death. I think 8 leading cause of death due to medication error.
To medical errors, I think.
Yeah, can I see the slide? Yeah, the slide.
It is the Institution of Medicine, and this is the report that was very famous. Yes. And I think the quality improvement center started from here. It's kind of an old report, but it's a very famous report actually. Okay. It's 1999.
Yeah, just I wanted to check with you the 7,000 deaths attributed to adverse events. Do we consider events as an error? It's not reaction. It's not an event. You cannot predict the event.
Yeah, unpredictable events here. But
do we consider it as an error?
No. It's not. But it was labeled before. I mean, this is an old. It's very famous, and everybody, any quality improvement lecture, you will find it here. This report, which is 1999, which was Institution of Medicine report, because it was an enlightening report, and it was initially said before. I mean, medication errors and adverse drug events before, but nowadays it's even not. Recently, they are not calling it medication errors. It's medication events.
Yes. Okay.
So any unexpected event, you might consider it an event, not like an error.
Okay. Thank you, Dr. Hamza. And I wish you can hold a workshop for such studies. You know, we for better appreciation of this great science.
Thank you very much, Dr. Iman. I think before we had like a tiny workshop or mini workshop, 4 hours. presented by Dr. Yasser as a director and myself. 4 hours, just we were introducing the science of quality improvement, KPIs, how to start, how to end.
Yes.
Yeah, you are summarizing the science of quality improvement. And I think we will restart this workshop after Dr. Yasser comes back, inshallah.
Okay, thank you. Good luck.
We'll
شكرا دكتور عبد العزيز. Okay.
شكرا دكتور أيمن.
This is very important idea really to restart those quality projects to help colleagues across the country to open the eyes on such important topics and to how to start those projects. We have as well Dr. Iman Mukhtar. Can you please unmute yourself and if you want to ask?
Hello, good evening all. Thank you very much, Dr. Aida, for the chance to talk. And I'm Dr. Iman Mukhtar, I'm your colleague from Eastern Province, Qutaif Central Hospital. I really thank the presenter and admiring the effort, great effort that has been conducted in the QIP and the fruitful discussion that carried out. I just have a question regarding the possibility of implementation or unifying your QIP-based results on the other ICUs across the countries and the provinces. Is it applicable that we can use the same system to unify it in our ICU? Basically, we do have a QIP of medication error reduction just conducted almost a few months ago. We're not done with our data and our results. And it's carried by one of our colleagues, Dr. Ahmed Khalifa, and our team in the PICU. My question is, can we use your QIP as unified to be used in the ICUs? Unified system, I mean.
Thank you very much, Dr. Iman. Yes, I think so. Well, I guess all this intervention that we have done, as I mentioned with Dr. Hani's question, I think is available in most of the ICUs in the kingdom. For example, the drug library, I think, which is embedded in the infusion pump. So it's available all over the country. So each PICU nowadays, it has an electronic infusion pump. So we are not using the manual anyway. We are using an electronic infusion pump. This electronic infusion pumps, just what you need to update the system to match the pediatric dosing. So you call just the provider, which is the company that you purchased the infusion pump from, and they will just install and update the drug library software to include the pediatric limits. So for example, if you will start morphine or midazolam infusion and your maximum limits for infusion, it's 100 or whatever the number, the infusion pump, it will not allow you. But this software is need to be updated, and it's easy to be updated. I think the company, when we told them we need to update the infusion pump to the pediatric limits because it was only adult. So they did it within a very short period of time. And the second thing, the order set, electronic order set, I think most of the PICUs in the kingdom also, they have now the electronic medical record for the patients. So it's easy. So you can just implement an order set, review it with the clinical pharmacist or the pharmacist and the nurses. And then whenever a resident or a rotator fellow will order an order, it will be through the order set, which is an already reviewed doses, dilutions, and so on. So yes, I think it's applicable. Again, just apply whatever you have. I think awareness is very important. Reporting is very important. I think all PICUs, they have a reporting system or a process to report an error, and you will take it from there. So what intervention you need, you just decide based on your local settings and manpower, capabilities, and so on. But all what we did during our project, I think it's available everywhere in the kingdom. I think you can apply it also.
Yes, sure. Thank you very much, Doctor. If you're conducting any workshops soon, please just spread the ad if we can, if we can attend. Thank you very much.
Sure.
Thank you, Dr. Aida, and the presenter, Dr. Abdulaziz. Thank you.
Thank you.
And the floor is open for any further comments or questions. If no more, I think it's time to conclude. So thank you very much for the presenting team for presenting such a very important crucial topic. Thank you for the attendee for attending this activity. Please enjoy the rest of your night and hope you will